Hello friends, hope you are all doing well. So after a long break, we restart our series of interesting cases. The plan is that I will share with you one interesting case a week. Before we go any further, please note that these being medical cases, all the information I share are up to date to the best of my knowledge as of the date of releasing this video. However, as we know in science, every few months, more so in retina, some new drug gets introduced or some new protocol gets found, and therefore what I say today may not remain relevant or up to date after a few months or years. Therefore, in case you are using this video as a reference to decide how you treat a patient or how you get your own eyes treated or how you get one of your friends or relatives or family members treated, please consult your ophthalmologist before making any final decision. And of course, remember this video is only made for an academic purpose. So there are no financial disclosures that I have relevant to this topic. Now let's start with the case. So today's case is a 54-year-old male who has type 2 diabetic since 8 years, and he came to us without any eye complaints. He just came for a routine annual diabetic retinopathy screening. On evaluation, this was his fundus status. These are multicolor 55-degree images using Heidelberg Spectralis machine. So you can see right eye there was a small flame-shaped hemorrhage. In left eye there were few microaneurysms. Visual acuity in the right eye was 20/20, in left eye 20/25. So we ordered an OCT scan. In the right eye, the OCT scan was absolutely normal. In the left eye, however, there were cystic spaces seen close to the fovea. And on the central macular thickness map, you could see there was thickness which was extending into the central subfoveal zone. So based on these clinical findings as well as the OCT picture, we diagnosed the patient as a case of mild NPDR in both eyes with left eye diabetic macular edema. So the question that confronts us is, how do we manage this left eye diabetic macular edema? Now a little brief about diabetic retinopathy and diabetic macular edema. So we know diabetic retinopathy is the leading cause of blindness and visual impairment in the working age population. And diabetic macular edema is the most common cause of visual impairment in DR, that is diabetic retinopathy. It can occur at any stage of diabetic retinopathy. Today, most people follow the DRCR guidelines while deciding how to manage a patient of diabetic macular edema. Now, DRCR is a clinical network which was established in 2002 and is supported by the National Eye Institute in the United States. Now, DRCR has come up with treatment guidelines for diabetic retinopathy as well as proliferative diabetic retinopathy and diabetic macular edema, which are based on major RCTs they have done. These RCTs were all organized by DRCR and not company sponsored, and therefore whatever guidelines DRCR protocol suggests are all based on level 1 evidence. And that's probably why nowadays DRCR protocols have become the cornerstone for current clinical guidelines. So when we look at DRCR protocol for management of diabetic macular edema, the first thing that we have to see is that what kind of DME we are treating. So DRCR has classified diabetic macular edema broadly into two groups, and this classification is based on OCT. First is the non-center involving diabetic macular edema, where diabetic macular edema does not involve the central subfield zone. And the second is center-involving DME, where the DME involves the central subfield zone. Now the central subfield zone is basically the central 1 millimeter diameter area of the macula. This is how non-center involving diabetic macular edema appears. You can see this intraretinal fluid and also some hard exudates. But if you see, this is the central subfield zone. You can see here the circle diameter is 1 millimeter. So this is 1 millimeter and this is the central subfield zone. But you see this heat or this thickness, area of thickness, which is clearly shown in this red pseudo color map of the central macular, the thickness map. So this area of thickness is lying outside the central subfield zone. Now compare this with this patient who has a center involving diabetic macular edema. You can see that there are cystic changes right at the fovea, and the fovea is also everted because of that. Now if you look at the central macular thickness map, you can clearly see that the central subfield is red in color. That means there is thickening inside the central subfield area. So if you just look at the CMT map, and if the central circle is green in color or blue in color, that means you are handling a non-center involving DME. But if it is red in color, that means the DME is involving the central subfield, and therefore it's a center involving DME. So what about our case? So if we go back and look at the right eye and the left eye OCT scans, we can clearly see in the right eye the central subfield is normal, but in the left eye, if you see carefully, you can see that there is redness which has started appearing inside the central subfield area. In other words, we are handling a patient of mild NPDR in both eyes with center involving DME in the left eye. So now that we know that according to DRCR we are handling a center involving DME, how does DRCR suggest we manage center involving DME? So the first step is of course to ensure that the systemic parameters, that means hemoglobin, blood glucose levels, blood pressure, lipid profile, renal parameters, all these should be well controlled. Now why is this important? Now though this has not been emphatically stated by DRCR, but remember, to get enrolled into the DRCR trials, a subject had to have perfect diabetic control. So that is the very basis, and even a good clinical practice recommends that before you do anything to your DME patient, please ensure that their systemic parameters are well controlled. So fortunately for us, on examination we realized once we did the blood investigations that our patient's systemic parameters were absolutely under control. So then what next? Now there are three options. We can give an injection, intravitreal injection. It can be an anti-VEGF or a steroid, or we can do a laser, or we may just decide to do nothing. So what does the DRCR protocol say? So one of the important RCTs that was conducted by DRCR is Protocol I. So this report came out in 2010, and basically this was the first time that RCT was being done in the anti-VEGF era. So after ETDRS, which was done way back in the 1980s when laser was the only option. So this was the next RCT, major RCT, where now we had more than options beyond laser. We had triamcinolone and we had anti-VEGF like ranibizumab. So the DRCR protocol I wanted to find out what was the best way to treat center involving DME. The study compared laser versus anti-VEGF with prompt laser or deferred laser. Deferred laser means where you treat for the first 6 months only with anti-VEGF and consider laser if the DME persists, and there are certain other criteria. That there should be treatable laser lesions which are suitable for laser therapy. So if anything like that happens and the edema is not going away only with in spite of 6 monthly injections, then you could consider laser. So this is anti-VEGF with deferred laser. That means no laser within first 6 months. And the third arm was where you give a triamcinolone and do a prompt laser. So I should rather say the fourth arm, because the anti-VEGF arm, there were two anti-VEGF arms. So after 1 year, when all the outcomes of all these four arms were compared, the anti-VEGF arm performed significantly better than both the laser as well as the intravitreal steroid triamcinolone arm. And this was true for whether you did a prompt laser or you did a deferred laser. But when you further analyzed, one realized through the study that the chances of gaining 2 or 3 lines of ETDRS on the ETDRS chart was significantly more in the anti-VEGF followed by deferred laser group compared to anti-VEGF followed by prompt laser. So the first finding was that anti-VEGF is better than triamcinolone or laser in handling center-involving DME. The second was that when you give anti-VEGF, it is better to combine anti-VEGF with deferred laser. So based on this, then should we, in our patient of center-involving DME in the left eye, just go ahead and inject anti-VEGF? Well, the answer is no, because there is a catch here. If you look at the kind of center-involving DME patients that were enrolled in DRCR protocol I, you will see the patients who were enrolled in the study, all of them had a vision of 6/9 or worse. So 6/9, 6/12, 6/18, 20/32 or worse. That means these were patients of center-involving DME with visual impairment. However, think of our case. Our patient has a vision of 20/25, that is 6/6 part on Snell's chart. So this is a patient of a center-involving DME with good vision. Therefore, we cannot extrapolate and apply DRCR protocol I findings to this patient. So the first thing that one can ask is then what do we do and how common is such a scenario? Am I showing you some case which is very rare? Well, the answer is no. The case I am showing you, that means a patient with center-involving DME but good vision, that is vision of 6/6 or 6/6 part, that is 20/20 or 20/25, was, is not uncommon. 40% of the ETDRS patients were in this subgroup or DME with no visual impairment, and in US 84% of the patients presenting with DME fall in this group. In India also, like for example, any patient who keeps coming for a regular DR screening is a bit serious about his or her eye checkup, it's not uncommon for us to find center-involving DME in those patients. Unfortunately, most of our patients present to us only when they are symptomatic. That means they are already losing vision. So naturally, they fall more often in the center-involving DME with visual impairment. But take it from me, and also based on the data that I have shown, that it's not uncommon to find the occasional patient of DME with good vision and no visual impairment. So DRCR has done another separate randomized control trial, the DRCR protocol V, which was specifically done to study this group of patients. And what the researchers tried to answer was, so in a patient of center-involving DME with good vision, what would be ideal? Should I immediately put the patient on anti-VEGF, or can I wait for the vision to drop before we start anti-VEGF? So what do I mean by vision to drop? So if the vision becomes 20/32 or worse from 20/25, that means 6/9 or worse from 6/6 part or 6/6, then the patient gets transferred to the protocol I group. And then we know that yes, protocol I has already said that we should immediately consider anti-VEGF. But is it right for us to wait for the vision to drop and then do the treatment, or should we not take any chance and immediately start injecting? So if we look at the study itself, the DRCR protocol V, now this was done at 91 sites in USA and Canada between November 2013 till September 2016, and 702 patients of center-involving DME with no visual impairment or good vision were enrolled. 3 possible treatments were offered. 1. Aflibercept, 2. Laser, and 3rd, no treatment, just observation. Now, in the aflibercept arm, patients were injected aflibercept on a PRN basis, no loading dose. And the frequency of the injection was up to every 4 weeks. And re-injection was done only when there was a drop in vision. Now, the laser could be done at baseline, of course. In the laser arm, we did a laser at baseline, but it could be repeated if required after 4 months. In the observation arm, where you are not doing anything, you followed the patient after 2 months, then again at 4 months, and then every 4 months thereafter. That means at 8 months, 12 months, like this. There was an option for shifting patients of laser or patients who are just being observed to the aflibercept arm, that is a rescue therapy. But what was the indication for rescue therapy? If there was a drop of vision by 2 lines at any visit, or a drop of 1 to 2 lines of vision at 2 consecutive visits. The important thing is that just an increase in central subfoveal thickness did not trigger a rescue anti-VEGF injection. That means injections were given only when the vision actually became 20/32 or worse, the 6/9 or worse. But if just the edema or if the OCT just showed that there has been a slight increase in the edema, injections were not given. So what was the outcome? There was no statistically significant differences whether you treated the patient with an immediate anti-VEGF or you did a laser or you just decided to observe. After 2 years, the mean visual acuity was same and most patients recovered to 20/20 or 6/6 vision. The proportion of patients who actually ended up losing vision and therefore requiring rescue therapy was less than 20%, so 1 in 5. Rather, patients who with observation had improvement or deterioration of DR score was also very less, 1 in 10. In other words, if we see that most patients did pretty well. 3/4 of the laser cases, that means almost 75%, and 2/3 of the observation patients did not need rescue therapy. That means they never had a drop in vision to signify an anti-VEGF injection. So based on this, the DRCR protocol V concluded that if you have a patient of center-involving DME with good vision and no visual impairment, there is no harm to delay anti-VEGF therapy till such a time that there is significant changes in visual acuity. So what about our case? So of the 3 options that we initially thought, giving an intravitreal injection, doing laser or doing nothing, if we go by DRCR protocol V, which we should because it's a level 1 evidence, we need to do nothing in our patient. So that's what we decided to do. So this is the patient at baseline, 20/25 vision, center-involving DME. This is with observation after 2 months, and you can already see that this redness has reduced. And this is without treatment. And remember, the patient had good systemic control at the baseline, from the baseline itself. And this is after 6 months. And now you can see this, even this small pocket of red or mild thickening has now resolved. And this area also has become green. And you can also see the cystic changes disappearing. And vision has now recovered to 20/20. So what did we learn from today's case? So the first thing is, when you have a patient of diabetic macular edema or even PDR and DR also for that matter, you should look up for DRCR guidelines, because DRCR has given guidelines on how to manage DME, PDR or even diabetic retinopathy which are all based on RCTs. That means that is level 1 data. Now, if you have a patient of diabetic macular edema, how you treat, if we go by DRCR protocol, how you treat will depend on the type of the DME. So if you have a non-center involving DME, do laser. If you have a center involving DME with good vision and no visual impairment, like our case today, that is vision of 6/6 or 6/6 part, 20/25 or better, you should observe and treat only if vision drops to 20/32, that is 6/9 or worse. If you have a patient of center involving DME with BCVA or with impaired vision impairment, that means of BCVA of 20/32 or worse, you should consider anti-VEGF. In other words, if we look carefully at the DRCR protocol, it is very clear that just by seeing some thickening on the central subfoveal field, on OCT, you shouldn't jump into giving injections. All center involving DME patients do not require injections. But before we conclude, let us look at the DRCR protocol V a bit more carefully. First, in majority of, there was a large chunk of patients in this DRCR protocol V who had very minimal thickening, just 300 to 400 micron in thickening in the central subfoveal field, a central subfield rather. A very few actually had very thickened edema. Now, what if you have a patient with good vision but a very thickened edema? Is it still justifiable to wait and watch, or should we treat? Now, there is no level 1 evidence to answer that question, but it is something you can, either we need to do more research on that line, or you can follow up your patients and take a call of your own based on a patient's individual characteristics. Second is, of course, as I said, in DRCR, it is very important that patients are enrolled only if they have good systemic control. It is not unusual for our patients in practice to have poor systemic control. So even if you control them initially, after few months, they again, start having elevated HbA1c or elevated blood glucose levels. So when you are deciding to just observe a patient, be very careful, monitor the systemic controls, systemic parameters. Because if the systemic parameters go haywire, you may even have worsening of DME, whereas you may then in panic consider injecting, whereas all that you need to do is to just control the diabetic level or the blood pressure or the lipid profile, and the patient's edema may actually regress. Third, patients of DRCR protocol, as I said, they were followed after baseline follow-up, they were followed again. If they were being observed, they were followed again after 2 months, then after 4 months, and then every 4 months. So it's a very close follow-up. So if your patient is unlikely to come back for close follow-up, then one has to think whether observation would be a good idea. Third, so this was the third point. And the fourth point, if we look at those patients who underwent laser therapy versus patients who underwent simple observation, the chances of such a patient ending up requiring an anti-VEGF were less in the laser group than in the observation group. So if you have a patient of center involving DME with good vision, and there are say few microaneurysms well away from fovea, which can be easily lasered, it probably makes sense to not just observe but also to do laser, because that way the chances of this patient actually requiring an injection even in future would be lesser compared to if you just observe. So I hope you found this case interesting. I hope you found today's discussion interesting. So next week we will have a presentation on multicolor imaging, and hopefully you will find that interesting too, because if you see, these are 3 multicolor images, and if you look at them with all this greenish thing, it looks very funny, isn't it? Normal retina do not definitely look like this. So the question I'll try to answer is, what is multicolor imaging? Is it just a funny looking fundus photo, or is there more to it? So do let me know through comments whether you like the case. If I have not been able to explain some aspect of today's case, or if you have any more questions, please feel free to get in touch. And thank you once again for watching this video. Thank you.